Dr. Matos, the screen is now yours.
Technology. As I said, I think if you haven't seen this slide, I like it because I was just saying that nature provides us with these beautiful examples of how we can do so much beautiful work together and how we can lead in a nice way and share places whenever needed. And that's why nature performs its tasks in such a beautiful way. So one of the things that I think about is that sometimes we worry too much about outsourcing our capabilities. And I'm not against any of technology. In fact, I like it very much. But I wonder if rather than worrying so much about putting computers in series and enhancing the capabilities of technology, if we could think about working with our brains in series rather than just with equipment, and perhaps having a way of controlling some black areas in our brains that make us believe that we are better than everyone else, that we know the answers to every problem, and letting us get together and collaborate more and hear more and use empathy a little bit more in the way we approach solutions for health and everything else in life. So what I want to talk to you is an idea that perhaps rather than worrying so much about globalizing the world, perhaps we should legalize the world. And let me tell you what this idea is, and then I'll show you a little example of that. One of the things that I'm worried in this globalized world is that every time we have a problem, it seems that we have a preset solution. But problems vary in size and in shape, and sometimes if we go into all preset solutions, they may fall short or be a little bit too much. And then perhaps rather than applying this globalized approach to many things, we should, every time that we have a problem, we should just sit together with those involved with that problem and hear more and collaborate a little bit more. And by doing that, I think we are able to lead by empowering people. And when I say this, and I say the importance of that, is that sometimes in medicine, for instance, the problem may be that you don't have an equipment to do a particular test, but sometimes you have the equipment, but you don't have the expertise. Sometimes you have both, but you don't have the motivation in that particular group to move ahead. So once we sit and we listen to the people that are directly involved with the problems, I think we end up getting not only the solution for the problem that we're looking, sometimes we find solutions to things we haven't even envisioned in the beginning, and sometimes we find new problems and you have to go back and start the whole thing. So that's what we call Legos, which is not only because the name reminds the toy, the Lego toy, but we use this as an acronym for lead by empowering groups to optimize solutions. So actually different groups will be at different stages of development, different problems will be there, and we should perhaps just start collaborating more and pushing things forward according to whatever needs every specific group has. So let me give you a Legos experience that we have. We are from Brazil, this huge country with major diversity, as you know. We have in the south the temperate weather, some cities and towns that look like European places. We have the Amazon forest, we have the Pantanal in the middle, and most of the developed cities are around the coastline. And we have the big cities here, and then you have the shanty towns very close to it. And in this area here, which is the northeast where I'm from, we have very, very serious droughts, and we have major problems with these people here. So I come from the state of Pernambuco, and until about 15 years ago, our neighbor state to the north, Paraíba, didn't have a structured program for heart diseases in children, for congenital heart disease. And what happened was that we had children having been transferred just to do echos in these places, and some children came in with very, very serious malnourished conditions and all this. So obviously morbidity and mortality was very high. So we had a challenge over there, which was, can we change this? Can we find a way that we can start from training and reach care and create a care continuum for a large state? Paraíba has about 4 million people, and we were asked to work together with them. So the initial design that we thought we would do is, if people are around and they spread out, we need to get them together. So we thought about doing a network. It's called the Pediatric Cardiology Network, which shows the places, and we linked everyone through telemedicine to our group here in Recife, a pediatric hospital and 12 maternities. This later expanded to 21 places. if the problem was cardiology. So it didn't have cardiology there. So we put 7 cardiologists on call here online, 24/7 every day in the week for the people over there. We needed to share information. So we developed a database, and we have this database that we could use for all these maternities and ourselves, so we could follow up the patients on this line. And finally, we decided to sit down and develop the network protocols, which we shared with everyone in the different maternity places. Then we decided that we had a level 1 screening, then a level 2 screening. I'll just mention it very briefly. This one is just with clinical examination and pulse oximetry, and this one is a bedside echo. And babies that obviously had abnormal exams would follow on in this route up to the care that was going to be given at the hospital that was part of the network. So the method that we had, we brought people over, and it was a very short thing. It was just a 1 day. During the morning, they would have theory about pulse oximetry, about echoes. We used this method that we say that the integrity of the cardiovascular system can be seen through these 3 letters, A, B, C. And the A represents anatomy. B represents the beating of the heart, where you look at the rhythm and the frequency, and C, contractility, which is the ability of the heart to pump. So in the first, you see most of the structural heart diseases. In the second, the arrhythmias. On the third, the cardiomyopathies. And there was a 4-hour session on that during the training. And then in the afternoon, they'd have practice using the equipment. Then we had this little method with a door and showing them how the system would work once they went back to their places. Then they received the manual, database accesses, and they would go back to their own places. And the initial thing was done in the network. So we go for results. And I must tell you that the initial results were absolutely dismal. The first thing was that we noticed that a huge number of children in the state of Paraíba were all blue babies. We're very concerned about this. Lots of results that were abnormal. So people got worried about these, and perhaps the nurses are not doing it right. But again, we sat down and collaborated with the nurses, and we found out that we bought these oximeters to do the pulse oximeter tests. And then careful observation showed that these tiny little fingers, very, very difficultly, very hard to be able to fit there. So we had to change everything. And then we had new proper pulse oximeters for neonates. And then fortunately, alas, there weren't that many blue babies in the state of Paraíba. We started having a good pulse oximetry result tests and working with that. Now, the second thing was the quality of the bedside echoes. You may imagine that after spending 4 hours with us, looking and hearing a lot about echoes, the next day, the quality of the echoes were absolutely poor, very difficult to make any diagnosis. But then we had 24-hour basis people here to sit and very patient, collaborate, and say, well, let's move this way and let's move that way. And then we had images. I know many of you are not in the medical profession, but this is virtually impossible to give any diagnosis. You don't know whether it's a very sick heart or whether it's a very poor image. But then around 40 to 50 exams that people did prospectively with help, we started getting very good quality images like this one, where you see the 4 chambers of the heart. It's very well aligned. And much more important than that, as people continued to do these echoes, we would not only have fantastic images, but we received things like these. Remember that they filmed the screen. So they usually filmed their own fingers pointing out to what they were seeing. And we became very happy that it was not only a good quality image, but the person that was doing that image was able to diagnose. And even if we weren't there, they would be able to follow on and know that this is a blue baby that requires immediate transfer to a hospital to have more access. So when we looked at that, we saw that we could significantly enhance the quality of the screening program. But then again, the challenges came. And the first one was we were identifying neonates, but not the older children. So we got together, sat with the people over there, and then we decided to do what we call the heart caravans. And once every year, we would go on to all visit these smaller places. And we moved on from 36 volunteers in 2013 to 120 volunteers that went well beyond cardiology. We had dentists, We had nutritionists, many other people doing this. In the beginning, the very first one was just to see patients, about 500, no training. And then this group that joined us, we were able in 2018 to be seeing over 2,000 patients and training over 2,000 professionals in each one of the towns that we visit. So it's a big change on that. And we realized that sometimes we saw them in 1 year and they had difficulty being followed up during their local places. So again, we sat together and we decided to do something. And we came in with the idea of opening heart rooms and an echo taxi, which I'll tell you what it is. Okay, so we had 3 places where we had a permanent room where patients would be seen. We asked other maternities to open that. So there were 12 maternities, trained everyone in the very same way, the cardiologists here, the pediatricians and nurses in their local places. We bought 3 big pieces of luggage, and inside those pieces of luggage, we put a portable echo machine, pulse oximeters, Holters, and all the equipment necessary to run an outpatient clinic. So we gave it a little nickname. People like that. It's good because they remember. So we called it the echo taxis and the heart rooms. And then in the first week of the month, we would have 3 of these bags in 3 of these maternities. It would stay there for the whole week. So we could run clinics and all these, and then it would move the next week to another one, and the next week to another one, and then back. And then every month we created another 12 new outpatient clinics that were going around. And then also because they were fairly close, see if a baby was born here and the equipment would be there, they could exchange it. And it was much easier to be doing echoes in all areas. And besides echoes, we were doing Holters to these little ones, which was something that hadn't been done before. So it was really very, very helpful. And I could stay a long time with this, but obviously we had short time. So I just mentioned we had challenges about non-cardiac conditions, neonatal conditions. We got people together and we expanded it to the training of perinatology. Then we had the Zika outbreak here in Brazil. And it was very nice because as we had established the training system for cardiology, we were able to train in the same model people to do the scans of the head. And in Paraíba, we had lots of very good results of early detections of microcephaly. Then we had problems with maternal health as well. And then again, we expanded this for an obstetric on-call team. So we basically paved the road with telemedicine for pediatric cardiology and expanded it into various things. So in terms of results, we were very happy with the results that we got from the pediatrics. We, in 7 years, screened over 230,000 children in the state, decreased mortality, provided a number of things. We expanded it, as I say, to perinatology, obstetrics, helped manage the crisis with Zika virus, then put technology to be used in remote sites, and we're able to keep a continuous medical educational program through telemedicine. And the most important thing is really that we had a significant fall in neonatal mortality rates because we established the network. So we started thinking about the neonates. Then we realized that we had problems that were outside cardiology. We put perinatology. Then we had the bigger children, we had the heart caravans, and then we had the open the places, and we had the echo taxis for people to be seen in their local places. Then we put the women, and we had maternal health and had multidisciplinary teams. So at the end, the design was very different from what we planned in the beginning, but with this idea of the Legos, we started mounting the little pieces to be able to help children in different ways and mothers, and to get a final design that was very helpful. So this is the idea. As I told you in the beginning, we say that LEGOS stands for Lead by Empowering Groups to Optimize Solutions. But at the end of the day, I think that's a better way for this acronym would be let empathy guide our solutions. So we think that really once you listen to people, once you sit down with people, once you listen to the difficulties and collaborate and try to find the best way to achieve results, we really can do a lot of things with not much resources and in fairly short periods of time. That's the idea that I had to bring to you. I hope I've been within my 10 minutes, and thank you very much.
Thank you very much, Dr. Matos. That was wonderful and really interesting.